The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today is Neuropsychiatric Symptoms and How to Manage Them. My name is Umbreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speakers, Dr. Jeffrey Wefel and Dr. Tresa Roebuck Spencer. Dr. Wefel is a board-certified neuropsychologist, associate professor, and Chief of Section of Neuropsychology in the Department of Neuro-Oncology at the University of Texas MD Anderson Cancer Center. Dr. Wefel's research activities seek to characterize the prevalence, pattern, course, risks, and biologic and neural substrates for the development of neurocognitive dysfunction associated with cancer and cancer therapies. Dr. Roebuck Spencer is a board-certified clinical neuropsychologist with Jefferson Neurobehavioral Group, who specializes in neuropsychological evaluation and treatment. She provides neuropsychological assessments for a wide range of conditions, including general memory and cognitive problems, traumatic brain injury, stroke, dementia, and other neurological and psychiatric disorders. She also provides psychotherapy for patients and their families who are adjusting to cognitive problems and assist with return to everyday functioning and responsibilities. Thank you both so much for joining us. You may now begin your presentation.
Thank you so much, Umbreen. Really appreciate the opportunity that ABTA has provided us to speak with you today on this webinar. As was mentioned, my name is Jeff Wefel, and I'm delighted to have my colleague and friend Tresa Spencer join me today to present to you on this topic. And particularly for Tresa, spending time lending her experience and expertise to helping us understand how to manage all these very complex issues that we're going to discuss today. Next slide. So these are our disclosures. I've received some research funding and do some consulting work with a number of pharmaceutical companies, and Dr. Spencer has no conflicts of interest to report. Next slide. These are the learning objectives that you had seen before in the announcement of the webinar. What we hope to do today is to cover an overview of the common mood, behavioral, and cognitive symptoms that are caused by brain tumors and their treatments, to help you to understand what some of the causes of these are, risk factors, and how they can evolve over time. And then to spend time talking about the impact that these neuropsychiatric symptoms can have on the patient and caregiving unit, and then learn about how we can evaluate and manage these through pharmacotherapies, psychotherapy, counseling, or perhaps even lifestyle changes. Next slide. So I think many of us are increasingly aware that the tumors that we're confronted with are now being evaluated and diagnosed using not just histologic features or how they look under the microscope, but also looking at genetic components of the tumors, creating what we call a molecular diagnosis. And we can now stratify these tumors into favorable and unfavorable tumors based on some of these molecular characteristics, leading to what appear to be improvements in survival time. Could you advance for me, Umbreen? Next slide. And we can see also that there have been some therapeutic gains here recently, some for specific tumor types, as we're seeing here in the left panel for lower grade IDH mutated tumors who receive certain therapies. There seem to be improved survival times. And in the right panel, you see for glioblastoma patients, the results from the recent phase 3 clinical trial that demonstrated that tumor treating fields were also pushing those survival curves out in a favorable direction as well. Next slide. And this is also true for brain metastasis patients, where we're learning better ways to stratify patients and their tumors and better ways to treat those tumors. And so these improvements in survival time have really caused us as a field to focus more and more attention on improving survivorship as well. Next slide. We know that in terms of brain tumor patients, that the vast majority of patients, over 3/4 of them, present with 3 or more symptoms that they're endorsing as being moderate or severe. And these include the most frequent symptoms being fatigue and sleep disturbance, cognitive changes, and mood disturbance, all things that we'll discuss here today. And for many patients, these are functionally limiting, causing reductions in our ability to work, to carry out physical activities or basic activities. And the neurobehavioral changes that can occur as well are also not infrequent, and these can often be the most difficult to manage. A small fraction of patients return to full-time competitive employment, and sometimes this is done with reduced hours, increased work limitations or need for time off, even if it's just to visit your physicians and healthcare providers. Next slide. The Jumpstarting Brain Tumor Drug Development Coalition, and I know that's a mouthful, was preparing for a meeting with the NCI, NIH, and FDA, and conducted a patient caregiver survey in which they asked the question, in addition to allowing a person to live longer, what would you most like to see future brain tumor treatments do? And some of the top answers included work on survival time and also work on retaining brain function, maintaining my ability to walk and perform basic physical tasks, and reducing the pain that I experience. So we know that this is a priority for patients and their caregivers, and we hope that the continued focus, the ongoing focus in clinical trials on these issues will result in better outcomes. And in the meantime, we hope to give you some very pragmatic approaches to helping to manage this as well. Next slide. So in terms of cognitive dysfunction, there are a lot of things that contribute to the adverse cognitive effects that we can experience when we're diagnosed with a brain tumor, one of which is where the tumor is located. And as you can see in this diagnostic phase column, I have a number of other circles, and I'll explain those here in brief to give you an overview of this, and we'll return to this graphic over time. So where the tumor is located can clearly impact the types of cognitive difficulties that we have. Our own genetic background that we were born with can impact how we tolerate some of the therapies and the likelihood of them causing cognitive changes as well in us. And we're beginning to appreciate that the molecular genetic features in the tumors themselves may also convey increased risk for cognitive difficulties. And I'll show you some of the evidence for that. Then what we call in neuropsychology brain reserve, brain resilience, and cognitive reserve also, we believe, kind of interact with our exposure to these therapies and modulate the extent to which we experience cognitive difficulties after being confronted with these treatments. And in the next column, you see treatment and survivorship phase. So for many of us, we've experienced surgery, radiation, chemotherapy, and maybe additional adjuvant therapies. And these all place us at risk for experiencing cognitive changes. Of course, we're also oftentimes living with other comorbidities, whether that's high blood pressure or diabetes. We're taking medications sometimes, and we may have psychological factors or neuropsychiatric phenomena that also interact with our cognitive ability. And all of these collectively impact on our ability to carry on life as we typically have known it in our home environment, our work environment, and our social lives. So let's first here focus on the impact of tumor location on cognition. Next slide. So the Glioma Outcomes Project collected data from a large number of high-grade glioma patients a number of years ago, and the clinical presentation, or the reason that people come to the emergency department or to their physician's attention, oftentimes is due to a profound change, a profound symptom, such as a headache or a seizure. But what I highlighted here in pink is the frequency of many of these cognitive changes also that are co-occurring at the time of diagnosis due to the growth of this tumor within the brain. Next slide. So this represents the epidemiology of the distribution of tumors within the brain. And what you can see is the most common areas that I've circled here for you are tumors arising in the temporal lobe and the frontal lobe. And as you can see in the table beneath this, in the first column of high-grade glioma patients, percent impaired, what this results in is a large number of cognitive difficulties in cognitive domains that are largely regulated by structures located in that area of the brain. This being things like our ability to learn new information and retain that over time, or learning and memory, and our executive functions, our ability to multitask, to reason, and make decisions effectively. You'll see that we have fewer deficits, but still quite a few patients experience difficulty with thinking as quickly as they're used to, being able to find the right words to express what they wish to say, understanding others, and manipulating things spatially. And I've also listed here in other columns the distribution of these deficits in other patient populations, like patients with meningiomas and patients with brain metastases. Next slide. So obviously, tumors don't all occur in the same place. They occur in many different locations, and that contributes, again, to the profile of cognitive difficulties that one may have. But the other question is whether or not these tumors are really focal, isolated lesions as we see them on the image, Or are there disruptions in different parts of the brain that maybe don't line up with the lesion location perfectly? Next slide. And in fact, that's really the case, is that oftentimes these cancer cells have kind of crept their way through the brain, and they're a little more disseminated than we can see on the scan. And this is the rationale for treating the brain tumors, not just with surgery alone, but also with some adjuvant therapies that can access more of the brain and get to more of those tumor cells. Next slide. What has also been demonstrated is when you measure the brain connections through things like magnetoencephalography, such as is done here, you'll see what this looks like in a healthy individual with no brain tumor on the left. You see all those dots and lines, and that represents connections between different parts of the brain. But in the patient next to this who has a low-grade glioma, as indicated by that red arrow, you'll see their connectivity matrix there to the right, and you'll see that there's a loss of functional connectivity, not just where that tumor is located, but also in the opposite hemisphere of the brain on the right side. And you can see that that disconnection contributes to some of the broad-based cognitive deficits that we see in patients that are not just localized to the tumor that we see on the scan. Next slide. So as I mentioned, some of the tumor genetic features seem to contribute to the likelihood of those tumors causing cognitive difficulties, and may also interact with our brain's ability to compensate for a growing lesion within the brain. And I'm going to show you data from 2 studies that we've done here at MD Anderson that underscore that on this next slide. So we had the opportunity to do neuropsychological evaluations on patients whose tumors were characterized genetically and grouped as being either an IDH wild type tumor or an IDH mutant tumor. And for those of you who don't know, the IDH mutant tumors tend to grow much more slowly over time, and they have a much more favorable prognosis for survival time. And those are plotted here across a bunch of different cognitive tests that we do with patients. And the IDH mutant patients are grouped together as red squares in that red line. And you can see that the higher you are on this graph, the better your thinking skills are in these different domains that are on the bottom: attention, memory, processing speed, executive function, and so forth. Whereas those IDH wild type tumor patients were having many more cognitive deficits. You can see as that blue line and the blue squares are suppressed below. So this suggested to us that patients with IDH wild type tumors presented with greater cognitive deficits that were likely secondary to the fact that those tumors were growing much more quickly and that they had greater lesion momentum, and that was likely precluding the brain's ability to compensate and reorganize for this new mass lesion that was emerging there. So this was our working hypothesis, and then we had the opportunity to look at the brain scans and begin to try to understand whether or not that was represented on those images of the brain as well. Next slide. So all these patients were seen before their surgery, and we had access to their scans, and we developed this imaging analysis pipeline where we did all these fancy maneuvers, if you will, that are represented here. And then we calculate a few connectivity metrics. Next slide. And what we were able then to do is plot one of those ball and stick diagrams like the one I showed you earlier with connectivity, and that's represented on the left. And the big green balls are where a lot of different sticks are crossing together and intersecting, creating what we call a hub region of the brain, which is a critical information processing region. And as we performed statistical analyses on these, what we found was that in those wild type tumor patients who had worse cognitive function because of a more rapidly growing tumor, they also had fewer connections. There was more disruption in brain organization, and they had fewer of those critical hub regions. On the right-hand side, what is being represented here is a mathematical property that talks about the structural organization and the efficiency of that organization. And what we observed was those wild-type patients also had a less efficiently wired brain than the IDH mutant patients. So this suggested to us, and these abnormalities were related to those cognitive deficits that we saw, underscoring how these molecular features that lead to different growth kinetics in the tumors that lead to different brain organization properties also are related to the cognitive deficits that we're experiencing. Next slide. Now we have that tumor as it presents, and now we want to get rid of that tumor. And usually the first step there is surgery. And next slide. The goal of surgery is to remove, oh, I'm sorry, next slide. Thank you. The goal of surgery is to remove as much of that tumor as possible, as safely as possible. And we know that if we can resect 98 or more % of the tumor, the contrast enhancing component of the tumor, that we can extend survival time. But we need to do that safely, because all those tumors are oftentimes placed next to healthy tissue and normal cells. And we want to prevent any sort of surgical related deficits to the extent that we can. Next slide. One of the ways that we've done that is to integrate neuropsychological assessment before and after the surgery, as well as during the surgery, what's called intraoperative cognitive monitoring. And so you'll see a bit of a workflow that we use here at MD Anderson and is used at many, many other centers as well, which is to do neuropsychological testing as well as functional MRIs on the left to try to understand the pattern of strengths and weaknesses, and then to look on fMRI for example, language centers, and to identify those for the surgeons so that they can use that to plan their surgery to make it as safe as possible. And in the middle panel, you see we have patients awake during surgery and they're undergoing cognitive testing. And we do that with some iPad-based testing here at MD Anderson, where we might have you name common objects as we're stimulating and determining if the surgeon were to resect that tissue, would it cause deficits, or would it look like the outcome would, that the function would be preserved. And this process of stimulation and testing goes on throughout the surgery to make sure that we can increase the safety of the surgery and minimize deficits postoperatively, and monitor that again with postoperative cognitive testing as well. Next slide. Then, as I mentioned, we move on oftentimes with adjuvant postoperative therapies, including radiation and chemotherapy. And the impact of those may be moderated or maybe affected by what sort of genetics we bring with us from birth. So I will show you some of that information as well. Next slide. The goals of radiation chemotherapy are fairly clear and fairly simple. They would like to kill the tumor cells and control tumor growth, but they also need to try to do this by minimizing any toxicity that we experience. And unfortunately, we have sometimes off-target toxicity, so where the radiation not only hits the cancer cell, but it hits some of the healthy surrounding brain around it. Or we may have what's called on-target, off-tumor normal tissue toxicity. And an example of this is when there is a receptor that the drug is trying to attach to that's on the tumor and block it so that it kills the tumor. But that same receptor may also be on our healthy cells. And so that drug doesn't know the difference, it just knows the receptor. And so unfortunately, the healthy cell may also be affected by that treatment, and that can cause toxicity. And frequently that will manifest as memory difficulties, multitasking problems, slowed thinking. We've explored a number of different ways to try to minimize that risk though. One of which is using techniques to try to reduce the radiation exposure to the normal brain. And this is done through radiation planning techniques, including things like intensity modulated radiation therapy, in brain metastasis using things like SRS or stereotactic radiosurgery, or if we're delivering whole brain radiation therapy, to use hippocampal avoidance when doing that to avoid a critical structure of the brain responsible for learning and memory. And there's also been interest in using a different form of radiation, and instead of traditional photon radiation, using proton radiation, which is represented in this graphic here. And you can see the difference between the amount of brain, the normal brain that's exposed to radiation when you use protons on the left, and all the gray areas not receiving radiation. Whereas on the right, using conventional radiation, you can see there's still a lot of low dose radiation exposure to areas outside of the tumor that increase the risk for cognitive deficits later on. We've also tried to incorporate cognitive outcomes into clinical trials so that we can select the most optimal therapy to improve survival and minimize side effects. And there's interest in developing more targeted therapies that maybe would not go to normal brain, but only go to those tumor cells. Similarly, we've studied some other pharmacotherapeutic approaches, drugs that may protect the brain when receiving some of these therapies. I'll show you an example of the use of memantine when given with radiation therapy to try to protect the normal tissue while allowing the tumor to be irradiated. And there's interest in studies involving metformin, ramipril, even things like exercise, and increasingly interest in regenerative medicine approaches that may be good for protecting or restoring cognitive function. Next slide. So what you see here are two summary tables from two clinical trials that looked at the use of stereotactic radiosurgery with or without whole brain radiation therapy for patients who had a limited number of brain metastases, 1 to 3 brain metastases. And what both studies demonstrated is that even though giving whole brain radiation therapy with radiosurgery resulted in better intracranial tumor control, so fewer new metastases, it did not increase in survival time at all. And patients that were treated with that combination had more cognitive deficits after treatment. So this shifted the way that patients were being cared for when they had a limited number of brain metastases toward the preference for giving them stereotactic radiosurgery, controlling that disease, and then preserving cognitive function for a longer period of time. So again, focusing on patient survivorship and quality of life, given that neither treatment was increasing survival time significantly. Next slide. In some patients, though, there's many of these metastases and whole brain radiation therapy is indicated. So we explored whether or not protecting the brain with that drug memantine that I mentioned before would improve cognitive outcomes when patients were treated with whole brain radiation therapy. So what you see is a schema where patients with brain metastases were randomized to memantine before and during radiation therapy, or to placebo, a sugar pill. And on the bottom, what you see is a chart that shows that the patients who received memantine before and during radiation had a longer time of good cognitive function before it declined after radiation therapy. So it was protecting the brain against those adverse radiation effects. Next slide. We also studied whether or not a gene that we are born with, some of us are born with and some of us do not have this, this polymorphism of this gene, would be related to the likelihood that we develop neurotoxicity when we were exposed to these therapies. And what we found was that in individuals who were carriers of the E4 allele on the ApoE gene, compared to individuals who were not carriers of the E4 allele, the E4 positive patients suffered much greater cognitive decline after receiving radiation therapy than those who were E4 negative. So this may eventually help us to identify clinically patients who we need to think about risk adapting therapy or monitoring more carefully, or using other neuroprotective strategies when they also receive radiation therapy. Next slide. Then we wed a few concepts together in the next trial where we said, okay, memantine is good for protecting the brain, but rather than just giving whole brain radiation therapy, maybe we could also avoid giving radiation to a certain piece of the brain called the hippocampus, using a technique called hippocampal avoidance to minimize the effects of exposing that area of the brain to radiation. And that area of the brain is really important for memory function. So we wanted to know that if adding hippocampal avoidance to whole brain and memantine would decrease our risk of cognitive decline. And in fact, that's exactly what we found, as you see here in the graph on the left at the bottom, that patients treated with hippocampal avoidant whole brain delayed the time until they had cognitive decline compared to individuals who received whole brain radiation therapy alone. And again, this came at no sacrifice to tumor control or overall survival time. Next slide. So now we're going to switch gears a little bit and talk about some of the neuropsychiatric symptoms that patients can experience. And we'll start with symptoms of mood disturbance. And symptoms of depression probably are one of the more common sets of adverse mood experiences that patients have. And this includes symptoms like feeling sad or empty and moving kind of counterclockwise in this circle, having feelings of hopelessness or helplessness, worthlessness, excessive feelings of guilt, lacking pleasure from common activities or what's called anhedonia. There can be increased anger and irritability. You can have reduced energy. There can be difficulties sleeping. There can be subjective cognitive concerns. There can be difficulties with concentration. We may have a lack of appetite or extreme appetite during these times. A lot of bodily signs and symptoms, what we call somatic symptoms. And then ultimately, of course, thoughts of death or suicide can be a part of this experience. Anxiety has a different set of feelings. It shares negative affect as a commonality with depression, but really it's predominated by worry, feelings of nervousness, restlessness, tension, feelings of impending doom, danger, panic. It can have physiologic experiences like racing heart rate, increased sweating, tremblingness. We can have that nervous feeling in our stomach that we're probably have all experienced at one time or another in our life. We can feel weak or lethargic. We can avoid situations that are anxiety producing, that we know elicit anxiety and worry in us, and we avoid those. This can, of course, lead to distracting thoughts and troubles with concentrating and focusing. And we can notice that not only is our heart racing and our palms are sweating, but maybe we are beginning to hyperventilate or breathe very quickly as well. Next slide. So we know that approximately a quarter of cancer patients experience depression during their illness, and this is far in excess of the normal healthy population, in which depression is experienced in only about 10% of individuals. But in the glioma outcome study a number of years ago now, after patients completed appointments with their physicians, they were asked to complete two different surveys, a 61-item survey in which 93% of patients rated some symptoms of mood disturbance. And when we looked at three questions specifically related to depression, we found that about 73% of patients were endorsing some component of depressed mood. When you then interviewed the physicians and asked them, what percentage of your patients were experiencing depression, their answer was, only about 15%. So you can see a profound disconnect between clinical providers and patients in terms of estimating these symptoms. And I always like to tell my clinical colleagues, my healthcare provider colleagues, that we really need to ask about these symptoms. They're being experienced very frequently, and we need to incorporate that into our care. And when I talk with patients, I like to remind them that we're not mind readers as much as we'd like to be. And it's really helpful if you also bring those up to us, because there are things that we can do about that. So we're trying to bridge this communication gap and make sure that we can get access to care to you much more effectively. Next slide. So some risk factors for experiencing mood disturbance include the presence of cognitive difficulties. These can be very frustrating, very debilitating, and cause mood disturbance. Physical impairments, inability to do things that we typically do. There's some inconsistent evidence that females may experience mood disorders more commonly than males. And we know that some of the anti-epileptics and cytokine therapies also can elicit mood disturbance due to their the way they interact with areas of the brain. And unfortunately, we know that less than half of patients diagnosed with a mood disorder are actually receiving treatment. And these treatments can be very effective. So, again, if we can bridge this communication gap, hopefully we can get care to those in need much more readily. Next slide. In terms of neurobehavioral changes and personality changes, families and caregivers say that the cognitive and neurobehavioral problems that their loved one experiences tend to be more troubling, and they're less clear on how to manage these than they are physical impairments like a gait disturbance, imbalance, for example. Next slide. Some examples of these changes that are common include things like having a reduced frustration tolerance, or feeling more irritable, having symptoms of anger or aggression, feeling a loss of emotional control, feeling apathetic, indifferent, withdrawing from things that you used to enjoy. On the flip side, some patients are very disinhibited and impulsive, and they lack self-awareness and may behave in socially unacceptable ways. And these last three in particular oftentimes are caused when tumors are located in the frontal lobe of the brain and are impacting networks within the brain that are responsible for our ability to evaluate our behaviors and enact control over our behaviors. And frequently larger tumors are more disruptive to many of these networks. Similarly, tumors in pituitary region can lead to hormonal changes that stimulate things like anger and aggression and frustration more than tumors in other areas. Some of the drugs that were prescribed, the corticosteroids in particular, things like Decadron, can lead to, again, some of these hyper feelings, what we call hypomania. It can lead to the irritability, and sometimes it can lead to frank psychosis as well. And some of the anti-epileptics, the anti-seizure medicines that were prescribed, we also know can cause things like irritability, depression, anxiety, and rarely psychosis as well. Next slide. So with that, I want to turn things over to Dr. Spencer to help you understand approaches to managing all these difficulties.
Well, thank you. I'm happy to be here, and thank you for the invitation to join in this talk. I think this will be a bit of a switching gears. I'm going to talk more about experiences for the patient and also for the caregivers, for individuals who have been diagnosed with a brain tumor. So I'm going to talk about the experience of that, and then how do you know when things are a problem, and then what can you do for yourself, and when do you need to reach out and seek help. Next slide. So I thought I'd start off with talking about what is expected for just sort of normal reactions or a normal adjustment when you're faced with loss or faced with a new diagnosis or faced with grief. And so I thought I'd use this model as a way of describing common emotional reactions that people experience. So these are 7 stages of grief that come out of a model from a Swiss psychiatrist and dates back to the 1960s or 70s. And this model is inspired by her work with terminally ill patients. And it's really meant to describe the emotional processes that people go through when they're coming to terms with their own death. But this model has resonated so well with people that it's been modified and used to talk about stages of grief or reactions to loss, and it's just been expanded out to help people understand what they're going through when faced with these kinds of situations. I think it's really also a helpful model to think about when you've been diagnosed with cancer or with a brain tumor or other significant illness. What are the normal emotions you might experience? The original model was 5 stages and it was expanded out to 7 stages. And I was going to go through each one of these emotions, if you will. I don't like to call them stages, even though that's how they're typically referred to, because you don't necessarily go through each one. You might skip a stage. They don't necessarily always come in this order, but this is the common range of emotional reactions that people have. The first that's described as shock. I can attest and share a personal experience in that I was also diagnosed with cancer in the last year, and I can share that this initial stage of shock is quite real, and it's described as, people feel numb, may feel disconnected, may feel detached, may feel like things don't seem quite real, because your sense of reality has changed. And I know that's true for many patients when they're diagnosed with a brain tumor or diagnosed with cancer, and they'll often refer to things like life before the diagnosis and life after the diagnosis. And it really has to do with this initial feeling of shock and getting through that. Secondly, people will experience what we call denial. And often people will use that term with a negative connotation, that if you're in denial, that's something bad, you're not accepting your situation. But really, denial is a healthy coping mechanism to help people deal with really extreme emotions when they're facing grief or loss. And so denial might be reflected as thoughts like, wow, I can't believe this is happening. I feel fine. This doesn't seem real. And just really not feeling like anything is really wrong, despite the reality that you've been given a diagnosis or experienced some loss. After denial, again, it may not come in this order. People may feel anger. And that anger can be reflected in different ways. You might feel anger at yourself blame yourself for something you've done. Did I cause this to happen? Sometimes that anger gets directed outward, blame or anger at someone in your life. Sometimes people are angry at their doctors or physicians, may not feel like they're being heard or may not like what they're being told, and may have extreme emotions toward their doctor and not realize why they're mad at their doctor. It might just be this externalizing the anger you feel at your situation. Another common emotion is that people will go through what we call bargaining. And that's just this way of trying to figure out, how do I fix this? What can I do? Can I turn back time? Can I go back and change my behavior? Can I go back and somehow do something differently? When people are in this stage, they may pray and they may, reach out and say, if I do this, can I please be healed? Maybe if I change my diet, maybe if I exercise, just really looking, sort of seeking a way to fix the situation they're in and turn it around. Unfortunately, in these situations, there's not often a way to do that. So people can't stay in the bargaining place for very long. And often when you come to that realization that there is no fix, people will go through a period of feeling sad and possibly even depressed. And so that usually comes with, well, I realize the situation is real, I can't fix it. And then this feeling of sometimes helplessness or hopelessness. And that can progress on to depression. And we'll talk about that in a few minutes. The next stage or process that people often go through, and this is one that can be really important if you're involved in treatment like psychotherapy, is called testing. And in this phase, people realize, wow, what realistic solutions can I find to deal with what I'm facing? So people may look to change habits. People may reach out for psychotherapy or reach out for treatment or may commit to treatment. So testing is a phase when people are really looking for some realistic solutions and trying them out in order to just sort of deal with the emotions that they're experiencing. And then finally, what we all hope for is reaching the point of acceptance, or you could say finding some meaning in the situation. And really what that means is, how do you find a way to manage the emotions you're feeling and accept them? Next slide. So this is a theoretical model, as I mentioned before, and it resonates with people, but since it is theoretical, it's based on other people's stories and experiences, and it doesn't have a lot of research behind it. So there's a lot of criticism in that it's this idealized way that people process emotions when they're dealing with loss or grief. But keep in mind, everybody's different. Not everybody experiences these emotions in the same way or in the same order. These stages don't necessarily follow one another, as I mentioned, and they don't have a timeline. So someone might stay in denial for a long time before they move on to anger, or someone may jump straight to anger and stay there. So everybody is different. And then I'll also mention that moving through these stages isn't a measure of success. So just because you don't feel like you've accepted your diagnosis or where you are doesn't mean that's good or bad. It's just where you are. And so, as I said, this is an idealized way of thinking about the normal range of emotions that people go through. But if you'll notice on what's on the right of my screen, it's more of a roller coaster ride or a back and forth in terms of the emotions that people may experience when faced with a new diagnosis or a terminal illness. And so particularly when you think about the brain tumor journey, you may not go through this pretty curve of denial and then getting to acceptance. You may start out with shock and then have sadness and then feel quite hopeful when you have clear scans or when you have the opportunity to participate in a clinical trial. But then that can quickly turn to sadness or discouragement if you face a recurrence or you hear about a death of someone that you're in a support group with who has the same diagnosis as you. And so that can put you right back at the beginning with shock, and then sadness and so forth. So this journey isn't linear. It can have stops and starts and really feel more like a roller coaster ride. And the other thing I'll add is, in the midst of all this, what we call sort of the normal adjustment and reaction, you also have all the neuropsychiatric issues that Dr. Wefel explained. You also have medication side effects and other symptoms that you can't control necessarily that are going to affect emotions at the same time that you're going through what we would call the normal reaction. The next slide. So I was describing normal adjustment, but when that goes awry, when we start to worry and think about treatment, are times when individuals may be showing signs of clinical depression or anxiety or neurobehavioral changes and cognitive changes. And I have slides on each of these, but I will try to go through them quickly because I know Dr. Wefel has already described them in detail. So next slide. So the first area that I wanted to talk about was clinical depression. And when do you intervene? And so depression is different from sadness, and I've listed the symptoms here. I won't go into them in detail, but when you're trying to understand sadness versus depression, depression is there are symptoms that are there nearly every day. They're global. They are significant enough that they interfere with an individual's, or they interfere with your ability to actually find pleasure in things that would normally make you happy. Sadness is usually around a specific issue, where depression feels all encompassing. So you might feel worthless. You might feel like nothing is good. And then those feelings may progress to suicidal thoughts and so forth. So when you get sort of to that level and you're starting to worry, this may be more of a depression than a sadness, that's when you would want to start reaching out and thinking about, what can I do? This isn't a normal stage of adjustment. This may be something that I need to intervene. The next slide. So when you think about, if you're starting to worry, I may be experiencing depression, this is more than sadness. What are some things that you can do on your own to get a jump start on helping yourself? The first thing, and this is going to be a common theme, is to get active. Physical exercise, physical activity to the extent that you can, or just some kind of activation is really important. So get moving and do something. Sometimes with my patients, I'll tell them, just do one thing, find one thing and do it, even if you don't feel like doing it. The other phrase I like to use a lot is action comes before motivation. So meaning, even if you don't feel like doing it, take that first step and do something. And then often motivation and desire will come next. Routines are important. So routines can help us to feel normal and can then start that sort of cycle into getting you more action, to getting you more active and feeling better. The next thing is definitely you can talk to someone. That sounds cliche, but it really does help. And then there's a lot in the popular culture right now about being mindful and finding things to be grateful for. So those are some great thought exercises you can do on your own. Find some self-soothing types of behaviors, like take a walk, paint, whatever it is that you enjoy, and get yourself involved in them. But if you're finding that those things aren't helping, that would be a time to seek help. And the steps are, let your doctor know. As Dr. Wefel said, they're not mind readers. And options for treatment include psychotherapy, so talking to a psychologist or other counselor, attending support groups, or even potentially taking medications that help with mood. So next slide. Anxiety is the second area where things can go wrong in terms of normal adjustment. I always like to start with saying that anxiety is normal. We all experience anxiety. It is our body's way of telling us or warning us that we may be in danger. Sometimes, though, that volume is turned up too high, and our body's telling us we're in danger when we're not, but we perceive that. There are a list of symptoms here that I won't go into detail because Dr. Wefel already did, but these are symptoms of anxiety, and often many of them are physical. So it's both the worries and the concerns about something that may be happening in the moment or may be happening in the future. But when it becomes an anxiety disorder, those worries become quite generalized and start to interfere with your everyday functioning and may even evolve and progress into panic attacks. So next slide. So when you're experiencing anxiety, what can you do? And so one of the first things that we try to help people do in therapy is to recognize what does anxiety feel like for you? How do you know that you're experiencing anxiety? And one example I can use is the term scanxiety. That's the anxiety that many patients with brain tumors feel when they know that scans, they're going to have to go in for an MRI. I've seen patients talk about being nervous for days leading up to their scans, where they can't sleep, and they just have a lot of worries, both the internal worries in their mind, but also the physical feelings of anxiety. So one of the things to do is to recognize those signs. The earlier, the better, so that you can start to turn them around. So for instance, if you experience shortness of breath, or you experience, like your mind racing or chest tightness, that would be the time that you would start to try to use some practice some calming strategies to help with that anxiety. So as you're recognizing the signs, you also have to know what triggers your anxiety. So in some cases, it might be a scan is coming up. Some places, sometimes it might be walking into the hospital. It could be the smell of alcohol because they're about to put an IV in. So those are the kinds of things that can trigger anxiety. So knowing that ahead of time and preparing for it can be very helpful. And so some of the strategies you can use on your own for anxiety included, very simply, slow down your breathing. People overbreathe when they're anxious. They tend to breathe too much. Their heart starts to race. And so the way that you can turn that process around is just to do some slow, deep breaths. You can also reframe any worries that you have in your mind, turn those into more calming, reassuring thoughts. Everything's going to be okay. I'm not in danger. I don't know the results of my scan yet. Be patient. I'll know tomorrow. So reframing anxious thoughts can be really helpful. Other things like change your environment, move, go take a walk, or do something that's relaxing or distracting can really help in the moment with anxiety symptoms. When those things don't help, I'm going to give you the same advice. Let your doctor know. Psychotherapy is incredibly helpful for anxiety. Support groups are helpful, and just knowing that other people are going through this as well and sharing those experiences. And then finally, medications can be helpful. Next slide. Neurobehavioral changes, Dr. Wefel has already talked about, so I won't go into them for the sake of time, but I would like to make a couple of comments. Next slide. So if you're an individual who's experiencing some behavioral changes, things like irritability, anger, frustration, or if you're a caregiver dealing with a loved one who's going through this, the first thing that is helpful to do is just acknowledge those feelings and validate them. Wow, I'm irritable right now. Please, be patient with me. I'm feeling really irritable. The next thing might be consider and treat the cause. Is it because there's too loud in the room? Is it a medication effect? And so forth. So figure out what might be the trigger for that behavior. You can adjust the environment, go somewhere else quiet. Often reducing stimulation is really helpful for things like irritability. So if there's loud music, bright lights, things like that, make it a more calm situation. You can redirect people who may be caught in a loop. If you know what the triggers are, you can avoid them. And most importantly, for caregivers and family members, staying calm. Even that can be very hard sometimes if someone's being irritable or angry with you, but staying calm and not taking things personally can go a long way. Often we are most angry and irritable toward the people closest to us. And so if you're a wife, a parent, a spouse, so on, you may get the brunt of some of these behavioral changes. And it's important not to take them personally. So this is a slide on cognitive changes, and I will be brief because I know I want to make sure we have time for questions. So Dr. Wefel has already described cognitive changes, and I've listed some here, but won't go through them again. So next slide. So cognitive changes, what could cause them? We already know where the tumor is in the brain, effects of treatment, but some other things can be contributing to cognitive changes that are more in our control. So things like not getting good sleep, having a lot of stress, having some problems with mood. And so it is important to recognize that there are some things that contribute to cognitive problems that you can manage on your own, or at least that piece of it you could try to control. So make sure you're getting good rest and what we call sleep hygiene, going to bed at the same time, just making sure you're making sleep a priority. Manage your stress and manage your mood. So don't let those two things get out of hand, because they can, whatever underlying cognitive issues you have, if you're not sleeping well and you're stressed, it's going to be much worse. So you can certainly let your doctor know if you're having cognitive issues, because the other issue, it could be related to medications or your treatment. And then you can always consider going in for cognitive testing or doing speech therapy or cognitive rehabilitation. So next slide. And then speaking of memory, because it's the most common issue that people ask for help with, and they always ask, can I do brain games? Is that going to help? Not really. There's not a lot of research that doing computerized brain games actually improves your memory. But we do know from research that the things that help are exercise, physical activity. It really increases blood flow to the brain, keeps your brain healthy, and that's probably the most helpful thing that we've seen in the research in terms of promoting good brain functioning. The next things are staying social, be a part of your community, talk with your loved ones, stay social, and then eat well, keep a good diet. And I'm going to defer to nutrition and dietitians on that, but we do know that what you put in your body helps with your mood and helps with your thinking. And then finally, keep your mind engaged. So you want to be active and stimulating your mind in a real world situation, not just with a computer game. So given the sake of time, I think I'll stop. I have a slide on specific memory strategies, and I'd be happy to share my email and send these out to anyone who's interested, but I want to make sure I leave time for questions.
Thank you so much, Dr. Spencer and Dr. Wefel, for sharing your insight. We do have some time for questions now. As a reminder, if you have a question that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. So one of the first questions we have, we've talked a lot about the different behavioral and cognitive changes that the tumor and treatments can cause. Are these changes permanent? Are they reversible?
You want me to take that one?
Go for it.
It depends on the cause. I mean, the brain is fascinating in that there can be transient or temporary issues that are going on that that can be causing the problems that you're experiencing. So that could be sleep, mood, stress. But if it's a function of treatment or tumor location, there is some natural recovery, neurological recovery that occurs anytime that there's been an insult to the brain. It's tricky with brain tumors, and I'll switch off to Dr. Wefel to comment on this, but when it comes to brain tumors, there's always the possibility of progression. And so while you may be experiencing neurological recovery after a surgery, you may down the road then experience some decline due to other treatment effects or tumor progression. So there's not an easy answer to that question.
You know, I think you've addressed it well. Absolutely. You know, when you have fixed lesion-based reasons for this, so a portion of the brain that is responsible for emotional regulation and doesn't recover well, then those deficits may be lifelong. But I think, as you know, Dr. Spencer already pointed out, a number of other factors may be transient, addressable, modifiable, and like everybody else, we have good days and bad days, right? So those things certainly are all just part and parcel of the experience.
Thank you so much. And we have a couple of questions here about some of the different symptoms that patients might experience. You know, these symptoms, they can be very regular, like experiencing fatigue or experiencing sadness, but how can a patient or their loved one tell when these issues start to become more than just a regular reaction to receiving news of a diagnosis like this and is something to be concerned about? You know, how do you know when too much fatigue is something to be concerned of? Or how do you know when those feelings of sadness are something to be concerned about when considering depression?
So that is going to be individual to each person, but certainly and to each symptom. So when fatigue crosses over to you know, sleeping all day, or has been a significant change or decline over a short period of time, that's when you really want to reach out to your treating physicians and other providers and let them know. When it comes to mood disorders like anxiety or depression, if you're starting to have thoughts of wanting to hurt yourself or harm yourself, or you're feeling worthless and like your life doesn't matter, and those sort of extreme types of emotions, those are definitely signs of clinical depression that you'd want to reach out to your healthcare providers. Anxiety, you're getting to a point where it's interfering with your everyday life and you're avoiding things that you normally would be engaged in, and you're starting to isolate, then you definitely want to reach out to your providers for help. Or you're starting to have panic attacks. That would be a more extreme form of anxiety. So, do you want to add anything, Dr.
Excellent. Yeah, no, I think it's very excellent. I think fatigue is maybe a little different in that I think well, I know it's the most common symptom that we see in a cancer hospital, fatigue. And so many patients are grappling with it. And I think the issue is one of how tolerant can we be to some changes that we have versus when that symptom just is, you know, severe and could be modified. And I think anytime it's interfering with activities that you want to do, it's worth exploring with your healthcare team whether or not there's some things that can be modified to see if you can improve that symptom. But we may ultimately be left with some degree of a symptom such as fatigue that we then have to adapt to.
Thank you so much for that insight. And can either of you share some advice for patients on how to be more proactive? You know, is there anything that patients can do ahead of time to better prepare for such symptoms?
It's a really great question. So we don't have any scientific evidence that says if people do these things in advance of surgery, in advance of radiation or chemotherapy, that they're going to have a better outcome at the end of that. There is a growing interest, I think, in the neurologic field of this concept of prehabilitation. Can we maybe exercise a little bit more? Can we cognitively stimulate ourselves? And will this help us be a little bit more robust to things like anesthesias and the treatments that we're going to undergo coming up? But I've not seen any studies in the brain tumor population that says these are ways to minimize the chances of adverse outcomes during those treatments. I think the thing that we can control, though, is what Dr. Spencer was talking about, preparing for the stresses of an illness and the things that may come, readying ourselves for that mentally, getting our support group and our network in place, just doing a little forward thinking and planning along those lines can help so we're not surprised and that we may be able to cope with the outcomes that are somewhat out of our control and probably likely a bit unpredictable as well.
And I would add that can help you feel like you have some sense of control, give some empowerment if you know, here are the triggers, here's things that make me tired, here are things that make me sad, here are the things that make me anxious, and have a couple of tools in your toolbox to manage them. And then to give yourself grace. You're going to have bad days. Some days you're more tired than others, and to try not to overgeneralize that I had a really bad day, that must mean I'm doing terrible. And to try to give yourself grace and say, let me just kind of give myself a break tonight and see how I do tomorrow. And for family members as well, caregivers, you're going through this at the same time as the patient. And so give yourself grace and give them grace.
Thank you. That is great advice. And I think we'll take just one last question. You both had mentioned the importance of communicating with your healthcare team. Are there tools or resources that you're aware of that can help patients and caregivers better track their symptoms and what they're going through? So then when they do have those appointments with their doctor and their healthcare team, they're better prepared with what to talk about?
So, there's some institutes I think are integrating electronic patient-reported outcome capture into their clinic experiences. So they're giving patients the opportunity to report in a standardized fashion a variety of their experiences in advance of appointments. And I think that'll be a vehicle for this, and maybe embrace that, take advantage of that. I think a low-tech option is to prepare for your appointments. So journal the important things for yourself, bring them on the piece of paper so you don't forget them, hand it to the provider so that they have it available to them. And so don't wait for them to ask, oh, did you record anything that you'd like to share with me? Being proactive about utilizing that appointment with your healthcare provider as effectively as you can, I think would be embraced by most healthcare providers. And the healthcare systems are attempting to create, I think, some digitized formats for that to also make it easier on the patients. I can't recall the names off the top of my head, but I know there are at least 2 tech-enabled devices and apps that have been designed for cancer and for a brain tumor patient population specifically. And one I know is coming out of Europe, in which it is an app in which you record things like your mood, your energy level, variations that you have over time, day to day, and that could then be ported or emailed out to whomever you'd like as a digitized journal of your experiences, of a way to help communicate what's been happening. But we're not using that here, and I don't know if any centers are actively employing that. But even the low tech approach, I think, would be very effective in working with your teams.
Great. Thank you so much. And thank you all for your wonderful questions. Unfortunately, that is all the time that we have for today. I want to thank again Dr. Spencer and Dr. Wefel for your wonderful presentation, your time and insight. We truly appreciate it.
Thank you.
Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or give us a call at 1-800-886-2282.